Thank you very much for the chance to come talk to you today. After spending the morning with you, I'm struck by how nice it would have been to have sat through this 4 years ago when we first started planning this residency. So I think what you'll see is some things that we did well, perhaps by accident, and then some missed opportunities, but really a way for us to be able to think about this going forward. So what I'm really going to describe is a neurologic residency program that we've developed at MUSC over the last 4 years. And first of all, what is a physical therapy residency? It's a different model than what you may be used to in the medical residency programs. There's no external funding for this. It's not part of our formal education, and it really is a voluntary program that individuals take up post-professionally to really seek out an opportunity to improve as clinicians. One of the products of this in a neurologic residency is that they may sit for a neurologic clinical specialization. It's not the goal of the residency, and there are programs designed to be able to facilitate passing the exam. That's not really what a residency is about. It's really about altering clinical decision making and helping somebody become a better therapist, but it is a byproduct of what it is that we do, and it is measurable. The last thing is that we really didn't go into this thinking that this was a business model. So our first idea in trying to develop this opportunity was as an education model and a way for us to be able to improve clinical practice, primarily with some of our close partners. So I went to the dean and presented this whole idea to her, and her first comment was, given the complexity of this, why would you want to pursue this model? And the answer really is, we've really felt very strongly this is our best opportunity to make a difference. And so if we could have a footprint inside of inpatient rehabilitation, it would give us a better chance to affect clinical practice than what we have seen traditionally in terms of didactically training our students and sending them out to clinical practice. The next comment was, that's fine, just don't ever ask me for money. I got to admit, this one was a blow. And because most therapy models are almost an apprenticeship, where you support the idea of a residency, you have 1 or 2 therapists come, stay there for a year, train with you, and then they go back and then pursue a job elsewhere. So we realized at the end of that, now we do need a business model. And this is a different question of how do we maintain revenue neutrality while we do this. So quickly, we did do a marketing analysis. We had 4 MBA students that were interested in working with us to develop a program. They surveyed Doctor of Physical Therapy students from 4 universities and people who had graduated within the last 3 years, and discovered overall interest and limitations to implementation. So specifically, they found that 79% of individuals were either somewhat interested or highly interested in pursuing residency education. In the Southeast, at this particular time, we only had 1 neurologic residency, and so this was for a very large group of individuals, so there definitely was a need there, but the limitations were real. So 94% of them feared the cost associated with this because many of the costs are assumed by the individuals. And the average indebtedness for our students after a 3-year program is getting close to $100,000 now. So to stop working and then assume the cost of a residency is very difficult. And also that they feared relocation. So over half of them didn't want to quit a job, move to a new site, be there for a year, and then go out elsewhere. So our unofficial mission of this program really became, how do we develop a program in which people who would otherwise not do a residency can engage in residency training? And so the business model goals were that it would not cost the residents any money, that the cost would be assumed by clinical partners. We charged $8,000 tuition. Total cost ends up being about $12,000 a year once you pay for transportation to and from Charleston and expenses associated with the specialty exam. We do not require any relocation, and I'll give you a few more details here in a moment. Minimal losses to productivity, so the individuals that are involved in the residency continue to work full-time and are expected to maintain productivity, and it maintains revenue neutrality for us, and then maximizes the investment of our clinical partners. So when we were trying to get the clinical partners, we really focused on the fact that they would have an opportunity to increase recruitment and retention of therapists, that they'd be able to market themselves differently, and really importantly to us, that they'd be able to have a culture change. So the program is 4 weeks in Charleston, so it's 64 hours of intense didactic training. We do about 120 hours remotely in a virtual classroom. We go out to each site 4 times or 3 times a year to be able to observe the resident and also the mentor-resident interactions, and they have to have 160 hours of mentor training. So for a decentralized model, this mentorship program is critically important. So our mentors at the facilities really are extensions of the faculty. And the difference between a mentor and a clinical instructor really is it's a different framework. You're collaboratively going through this idea of how to be able to improve decision making, and you're really working on advanced reasoning and advanced skills rather than basic competencies. So they complete an online certification for us as well as ongoing training throughout the year. We invite them free of charge to participate in any didactic training that the residents go through because they have to know the material that the residents are getting, and they have to have specialty certification or at least 3 years in the specialty area. So our outcomes, I mentioned early when we started, this was the map of the United States. When we started the residency program, there were 14 sites and only 1 in the Southeast. 4 years later, this is our footprint. So we have 11 sites in 7 states and have had 21 residents enrolled. 9 of those sites are affiliated with Health South. One of them is Roper St. Francis in Charleston and Wake Forest University in Winston-Salem, North Carolina. So looking at data from an individual site, and this is from our partnership in Anderson. We chose this one because they've had a resident all 4 years of the program. Financially, they see a difference in terms of recruitment. They used to have positions open for as much as 6 months. They now have a waiting list. 3 of their last 4 hires sought them out specifically because of the residency. They were spending as much as $20,000 in recruitment and startup cost. Now that cost is down to $3,000 in a minimal startup package. None of our sites were systematically collecting outcome measures. Now in Anderson, 125 of the 220 patients with stroke who were seen in their facility last year were seen by somebody associated with the residency. So there is a systematic application of what's happening here. The results of this, they've had a 14 or 15% higher discharge rate to the community. Their length of stay has decreased by more than 2.5 days. Their FIM change, which is a functional independence measure, a standardized measure in inpatient rehab, has gone up. And so that increase in FIM score in a smaller number of days also leads to a higher FIM efficiency, and that equals money for inpatient rehab because that's part of the proposed reimbursement. Their discharge FIM increased a lot relative to national averages within Health South. Patient satisfaction ranked 7 out of their national hospitals, and the overall ranking was 4. Now, this is a highly functioning facility to begin with, but it's important that even though they were highly functioning, they did seek out this opportunity over and over again and have been a continual partner and have said they're going to continue partnering until every one of their neuro patients are being seen by somebody within the program. Our value is that we have developed our clinical partners for sites for our entry-level DPT students. We create revenue for strategic planning that sits outside of our budget because this is not part of our DPT program, so it allows us a little bit more flexibility there. And we're developing our clinical partners for potential comparative effectiveness and pragmatic trials to be able to grow the research associated with actual care. We have 1 pilot study currently funded and are planning a larger pragmatic trial. So things that we need to do in the future, we need to put a dollar amount to the length of stay gains. How much does each day actually make for the facility? We go in the process of computing a metric for value based on cost, outcomes, and the patient satisfaction data. The other part of this, to be able to be involved in these pragmatic trials, our outcome data are not just going to be limited to FEM. So we actually will get physical performance, patient satisfaction, and quality of life data that they're not currently getting. So we need to calculate the cost associated with recruitment, retention, and marketing to be able to evaluate the impact of the residency. Right now, those numbers are generated nationally, and we need to be able to look at a per site, how much fewer resources do they need to be able to maintain a faculty. And then to continue to develop clinical partners as models for these trials that we're involved with. So thank you very much, and I will look forward to taking questions.